Hello everyone, my name is Disha Kapoor. Me and my colleagues have completed review of literature and we have narrowed down 8 research articles which are discussing about computerized dynamic posturography. So I wanted to discuss those articles. So let's get started with that. So what is CDP? It assesses a patient's balance function using a computerized platform. It can be carried out in a clinic or a rehabilitation gym. It takes around 20 minutes to administer the test. So first of all, what is CDP? It involves placing the athlete on a platform and it measures postural strategies. The platform will be static or dynamic. The system will be capturing the response from the patient or the athlete, which is basically the ability of the athlete to balance. It determines the individual's use of sensory system, which is somatosensory, visual, and vestibular. And these systems are responsible for postural control. So there are three subtypes of CDP. The first is sensory organization test, which is called SOT. Second is motor control test, and the third is adaptation test. So how it works? This test is composed of 6 conditions that become progressively more difficult, whereby in which the patient or the athlete must maintain the best balance possible in the face of compromising visual or proprioceptive cues. There are 3 trials of each condition for the reliability purposes. So the first, second, and third condition is the condition in which the surface is stable. The fourth, fifth, and the sixth condition is the condition in which the surface is moving. And in second and fifth, the eyes of the patients will be closed. And in third and sixth, the visual conflict will be there. In terms of application, I want to discuss one cross-sectional study. The aim of that study was to evaluate the balance in patients with vestibular dysfunction, and CDP was used as an assessment tool. In that particular study, 116 individuals participated in that study, and they were having some form of unilateral or bilateral peripheral vascular or vestibular dysfunction. And the patients with central vestibular dysfunction and having motor impairments, visual impairments, or any major psychiatric disorders or any kind of visual impairments, the patients were excluded. Apart from that, what they have basically done in the study is SOT, MCT, and the adaptation test. And as I have explained earlier, in the SOT, all the 6 conditions were done, and in the motor control test, the platform was translating in different directions, and in the adaptation test, the toes were moving up and down according to the platform, and hence the extraction of their postural responses were done. Apart from that, the two proportion equality test was done in terms of statistical analysis, and what they found was SOT was the most sensitive, and the condition number 4 showed highest risk of falls, and condition 5 and 6 showed greater number of people with falls during the test. MCT was the lowest rate of falls in the sample, and condition 1 of SOT showed the lowest risk of falls. Condition 4 was the highest impacted in these individuals, and the balance index showed 63.41 percentage of the elderly women had scored below normal range. There is one more study which I wanted to highlight here is targeting athletes. So the aim of this study was to determine the effect of regular soccer training on the balance system for young women. And there were 2 groups in this study. The first group included 25 individuals who were footballers, and the second group was the individuals who were students actually, and there were 50 participants in that particular group. And similarly, in this study also, the SOT, motor control, and the adaptation test was conducted. And let's have a look at what they actually did. So in terms of procedure, first of all, the informed consent was signed, and then the questionnaire was taken, and in that particular questionnaire there were few general health related questions like health problems, any surgeries, or recent hospitalization, or any kind of brain injuries. Apart from that, a short lateralization preference test was conducted, and in that particular test, it included like kicking a football, stepping on a chair, or throwing a small object. After that, the whole procedure was conducted, including all the tests which I said earlier. And in that particular test, it was found out that the first group in which the soccer training was done for 6 years, there was a difference found out in the asymmetry of loading in the lower limb in the footballers, which arises from using the dominant leg during the game. Apart from that, the footballers made better use of the vestibular system to conduct the test, and they prefer to use left leg more compared to the another leg, and there was no significant difference found out in the postural responses and the adaptation test. In terms of efficiency, hereby I wanted to discuss one article which has assessed the test, retest reliability, and minimal detectable change, which is called MDC of the Proprio test, which is a part of CDP. And in this study, the TBI patients were included, and they were having the history of severe traumatic brain injury. In this study, the post-injury duration was 9 months, and they were not having any history of cardiovascular diseases, and the functional independence measure score was greater than 5, and the Rancho's Loss Amico score was greater than 6. In terms of protocol, the sessions were divided into three sub sessions between 24 to 72 hours apart, and they have taken the informed consent in the first session, and they have taken few balance tests, which I will list out here. The first was activity specific balance confidence, dizziness, handicap inventory, Berg balance scale, and dynamic gait index. So their balance ability was assessed, and after that, in the other two sessions, the CDP system was incorporated. Okay, and what they have basically found out in terms of test retest reliability, the two-way intra-class correlation coefficient was done with a 95% of confidence interval to analyze the reliability. And for the minimal detectable change, the SEM and the z-score of 1.96 was taken. And what they have basically found out is the reliability was excellent, having the value of 0.9, and the minimal detectable change for the SOT value was 8 points. This is a very critical aspect which they have taken in consideration, which is MDC and SCM, which basically describes that how the individual has progressed from the initial scenario to now, which is a very good part. Hereby, I want to discuss a little bit about that what is minimal detectable change. As for example, the value is 4, and in your study you found out that the value of your particular assessment tool, the patient has progressed to 6 points. That means the minimal detectable change was actually 4, but you have scored 6. That means that that particular score is significant, and if you do not found greater than 4, for example you found out 3, that means that that value is of no use. In terms of efficiency, I want to highlight one more article which targets on to find out the reliability and discriminant validity of the SOT test in patients with multiple sclerosis. In this study, 30 individuals participated, and the SOT test was conducted at 2 visits 14 days apart. The eligibility criteria to participate in the study was the age was 18 to 60 years, and the ability of the walk should be at least 25 feet with bilateral support, and the assessment tool, that is patient determined disease steps scale score, was at least less than 6, and the exclusion criteria was wheelchair dependence, inability to ambulate, and having another neurological conditions beside multiple sclerosis, and having major issues with balance in the past 2 months were excluded. Similarly, apart from this, the SOT was conducted, and all the six conditions which I explained earlier were inculcated, and the disability status was actually categorized into two parts with the help of the scale which I just mentioned. So the lower disability group was there, and the second was the higher disability group. In terms of statistical analysis to find out the test retest reliability, the interclass correlation coefficient was done, and to find out the discriminant validity, the two-sided t-test was done, and the alpha level was set at 0.05. So what they have found out basically was the reliability was 0.84 in the lower disability group as well as in the higher disability group. And in terms of conditions from 2 through 6, it was found that significantly higher group was there in the lower disability group compared to the higher disability group in terms of equilibrium scores. Apart from that, what they have mentioned in terms of limitations is there is requirement of larger studies to come to a conclusion, and PDSS was not the accurate assessment tool, what I feel, and EDSS is basically the scale in which the multiple sclerosis can be categorized in three different categories like sensory, pyramidal, and cerebellar, and different psychometric properties should be taken in consideration apart from reliability and validity, which is MDC value, because as the population changes, the psychometric properties vary. So overall, I want to just highlight few of the limitations from the studies which I highlighted, like small sample size, unequal sample size in two groups, taking not appropriate assessment tool. So future studies are recommended to highlight the psychometric properties which is not taken in consideration. So hereby we are approaching towards the end of the video, and I wanted to say a few things before I end, that CDP does not only diagnose that which system is affected, but it also says that which is the system the patient is dependent on. That actually helps the therapist and the physiologist to actually design a protocol and ultimately decide the prognosis of the athlete. So thank you so much, and if you have any doubts you can email and ask, and have a nice day. Hope you enjoyed this video.